And then in June, I get a little note, don't forget about being on the radio. And I said, what? I have to be on the radio? Because I don't really mind talking to live people, but I'd never talked on the radio before. So I was on the radio yesterday. I pulled it off, it was okay. My practice is in the Artisan's Courtyard. Many of you know that. I see a lot of familiar faces in the crowd. It's a beautiful office. It's a little unusual in that I don't bill insurance directly, so it's called a cash-based practice, which doesn't mean you have to show up with nickels and dimes, but it means that I don't. Yeah, has to be tens and 20s. I don't bill insurance directly, so patients pay me up front and then they submit to get reimbursed. It's a little bit unusual, but I find that it makes the patient relationship very clear. I work for you, you're in my office, it's one-on-one, and you've got me for the time that you paid for me. So just a little bit different kind of a practice that you might not be familiar with. It's a solo practice. I share the office space with another physical therapist named Jeff Gordon. He does a lot of the same kind of treatment that I do, a lot of outpatient orthopedics, which is dealing with muscles and joints and bones and things like that. But he also has his own specialty, but he runs his own practice. I run my own practice. We just share the space. And it's a beautiful space, and some of you who have been there can probably attest to that. We're working from this one. So talking about dry needling, and dry needling is primarily use of a single-use needle. It's called dry because I'm not injecting anything. It is the same thing, same kind of needles that acupuncturists use, and it is primarily to inactivate a myofascial trigger point, which I will explain to you what it is. The needle itself is this tiny little thing. This is the plastic tube that helps me to insert it. And it's so fine, look how bendy it is. So it's nowhere near the diameter that you use to inject things. So it's very fine, it goes in quite easily. There are a couple of reasons why this treatment is really helpful for patients and for me. It's primarily to release that trigger point. I'll talk more about what the trigger point is. Intuitively, you all know what it is. It's that knot that you wish your husband would just rub some more, frequently, or those hard spots in the muscle that just like to be rubbed. That's a trigger point. That's intuitively what it is. It helps to bring blood flow to the area. That area of the muscle is in a state of contraction. It's as though you were squeezing your fist all day long. The reason your knuckles are white is because it's not getting good blood flow to the area. So it changes the chemistry of that tissue, and it changes those muscles those tissue fibers can shorten if it's there for a long, long time. Some of you probably have trigger points that have been around for weeks, months, years. So you know that feels like for it to have it be so shortened. And this can, sometimes it can work right away. Put the needle in and the muscle just kind of relaxes and goes away. It is not the cure in itself. Usually by the time the person comes in to get treated, by the time we've decided that we're gonna needle, I've already looked at your body part, shoulder, let's say. I've already seen what your range of motion is like. I've looked at your flexibility. I've looked at your strength. I've looked at how you're moving, because the needling itself is not going to cure the problem if you continue to talk on the phone all day long and run your mouse like this and drive like this. That trigger point is going to stay there, or it's going to come right back as soon as you get back in your car and drive like this. So it's just a part of the whole treatment process. Helpful to me because I can work on a trigger point sometimes for 20 minutes and it's not releasing and it's not really changing. Put the needle in, sometimes right away I can get a result with it. And I use my hands all day long. I'm always working on people, and I thought 3.5 years ago when I went to get this training that this would be really helpful because my hands are getting older, just like yours are. I'm not having any problems with them, but this is much kinder on my hands, so it allows me to rest them a little bit more. As you can see up there, you can use it on other areas for scar tissues, on tendons, on ligaments, but we don't have as much research for that. So primarily the target for me is getting on those myofascial trigger points. So like I said, there's trigger points, you kind of already know what they are because you have felt them in your own muscles. But the definition is that hyper-irritable, palpable nodule, feels like a lump, a hard knot in there. Usually it's within a top band, so sometimes it'll feel like a cable, and then there's one spot along that cable that you go, oh yeah, that's the spot. It's painful if you press it. If you try to stretch it sometimes, you'll feel it. Or if you overload it, or like you go to work, you know, that's the 99th time that you've swung that hammer, or the 99th time that you had to lift that whatever up into the cabinet, and the muscle just says, oh, I've had enough. And that's because it's been in that contracted state for a long time. Usually when you compress on that spot, it'll also refer pain someplace else. So sometimes the pain down your leg might not be a problem with that leg muscle. Sometimes it's a problem closer up, and we have to look and see what other trigger points might be causing that causing that pain. In the late 90s, there's been some advancements with technology that allow us to see it. It doesn't show up on an MRI. Like you get an MRI and you can get an X-ray, and the doctor says, oh, looks fine, you know, there's no broken bones, and your discs look fine. Well, that tissue doesn't really show up, that hyper-irritable nodule doesn't show up on normal MRIs and X-rays, but there is some new musculoskeletal ultrasound. It's kind of a new thing that it can show up on, and the Doppler studies is they're actually listening to the electrical activity in that muscle. When you send a signal from your brain to a muscle for it to fire, that's an electrical signal, and when they listen with Doppler studies, they will hear lots of static in that area because those muscles are active when they should be at rest. So contracture means that muscle has been contracted for a long time. Contracture of the tissue leads to hypoxia, which is lack of oxygen, and ischemia, which is lack of blood, like we were talking about with the squeezing of your fist. So the technique is, patient comes in, they tell me about their symptoms. I am listening to them, their normal clinical evaluation to see if I think, you know, what's the source of this pain. Unless you come in and you say, the horse kicked me right there. You know, many times it's not that clear cut. You don't know really how that started, or it didn't start until after the 5th mile of the hike. So I'm going to do a full assessment and see, is the pain coming from the muscle? Is it coming from the joint? Is it a ligament issue? Is it a neurological problem? Is it something more sinister? Is it a tumor? You know, things like that. So do a regular clinical exam and see if this is part of the picture. Now, if you go looking for myofascial trigger points, you will find them anywhere. Even if the problem was originally a broken ankle, you're probably going to damage the soft tissue as well. If the force was large enough for you to break a bone, then there's going to be some soft tissue damage as well. So just because I find the trigger point doesn't mean that that's the only source of the pain. So it's often a part of the whole picture of what's giving you grief. So find the trigger point, I can feel it, you confirm it and say, yeah, that's what I'm talking about. And then I have a choice of different needles. If you have very big muscles or it's a very deep trigger point, I have long ones, some on the head or like the scalp where there's not a lot of muscle. I can go with little teeny ones. So I will pick the length and the size of the needle that I need depending on where the tissue is. And then I put the needle in and I take it out and in, I redirect it to try to get all of the trigger points. Some trigger points are pretty big, especially if it's a big muscle or you're a big person. Once the needle goes in, many times the muscle will twitch. And that is in confirmation that you have hit the trigger point. Because if you go into a muscle that does not have any issues, it doesn't twitch, and most of the time you don't feel it. If I miss it, I can stick a needle, one of those big ones, in you. It can be this deep and you don't even know it's in there. So if I haven't hit anything I'm not supposed to hit. But, so you will feel, oftentimes the patient will feel it twitch, and I will try to elicit as many of those twitches as I can. I can also sense with the tension and the resistance on the needle whether the muscle has relaxed, much like I can when I'm doing manual work using my hands. And then when either it's not twitching anymore or feels like it's softened up and relaxed, I take the needle out. So it takes just a couple of minutes. I have somebody who's going to let me needle her so you can see. Joan, can you come up? This is Joan. She's an occupational therapist. She's a great referral source for me. I have already looked at her before, and I'm familiar with some of her muscles. So we're going to needle something that I've already assessed previously. I didn't want to just drag somebody cold out of the audience. So she was last minute substitute for somebody who couldn't come, so I need to confirm with her about some things. I was thinking we would do upper trap because it's been an issue. Yeah, this, yeah, okay. All right, so I'm gonna have her lie on her side with the pillow underneath her head. I'm gonna work on her upper trapezius. So this is also a very common one for people. You know that, like, how this always gets caught up, this muscle up here. So there's a couple of things to be cautious about when I am needling shoulders or anything where the lungs might be. I don't want to poke a hole in her lungs. So you have to know where you're going, you have to know your anatomy, you have to know the depth, and you have to choose the right length of needle and go in the right direction. Sometimes I am intentionally heading for a bone because if I hit the bone, it feels like a bone, it feels hard, and I will know where I am, just it's confirmation. I don't do a lot of bone pecking intentionally. That's one technique, but I don't do that. I am going to put a little alcohol on the surface of her skin. The nice thing about needling, like I mentioned before, is that I'm not injecting anything, so there's very little chance of an adverse reaction because I'm not adding anything to her system. I'm going to glove up. I very rarely see a drop of blood, so don't freak out. You're not going to see her spurting out or anything. I needle every day. I see less than 1 drop of blood per month. The drop isn't even, you wouldn't even call it a drop. It's just, it's so tiny. Okay, so this needle is in this plastic tube to make it stiff so that it can go in the skin. Because if I just tried to put the needle in, it would just go bendy, 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 especially if I used a really long one. Okay, anybody gonna faint or anything? You can just look away if you don't want to see the needle. So the other thing that I will often do if I am needling this is if I pick this muscle up and I'm kind of doing a pinch grip on her, that way I know the muscle, the trigger point and the muscle are right in between my fingers. So I know where I'm going and I'm not gonna go into her lung. So I think normally I might go from behind. I'm gonna go in front so you can see. I'm hesitating because there's several to choose from, isn't there?
Yes.
Okay, so there's my little tap. The needle is in. I can take this tube out. I'm going through the skin. I just felt I could poke through the superficial fascia. And then I'm on the trigger point. Yes, Joan? Mm-hmm. See her eyelids go flicker, flicker, flicker. She promised me she would not curse a blue streak if I used her today, though.
Or scream.
Oh, there's the twitch. I go slowly when I do this, going in and out. One of my instructors goes fairly quickly. I think I'm being kinder, but you know, I don't know. Maybe I'm just a wuss. So the whole time I'm in there, I am monitoring for tension and resistance on the needle. I just changed the direction and now I'm on to something else, right, Joan? Mm-hmm. She's loving it. There's another twitch. And I can feel with my fingers, even though I haven't moved them, that there's more that side. So I'm going there with the needle. Okay, I'm coming out. Before I take it out all the way, I usually reassess. Did I make a change in there? Did I change that tissue? I think I did. If this was a real session, I would go more here. There's another twitch. I could feel it to the front of where I needled. I could feel that there was still the muscle still contracting, the trigger point, and then I kind of pull it out and I put a little pressure. I keep pressure on there for about 30 seconds afterwards because I read a study that said if you do, people have less residual pain afterwards. So I thought, what the heck, I can hang out for 30 seconds. Then, after needling, sometimes there will be soreness to that tissue to touch, just like if you had a flu shot. sometimes the muscle will feel like it has had a workout, and it feel like, sore and stiff, like, ooh, I did something there. And part of that is because the needling, it induces a little bit of bleeding in there, and it reproduces that healing response that your tissues have the day after a hard workout. So then I go back and I reassess and I say, oh yeah, that's absolutely lovely. I would do more if she was actually my patient. She can can you tell them anything about what it feels like?
Yes, it definitely feels like the muscle relaxed. And isn't as tight as it was.
I did not pay her to say that. Thank you very much, Joan. And then this goes in the sharps container.
Done?
Thank you. Yes. So usually that would have to be followed up. I would have already talked to her about, why is that occurring? Many times when a muscle has a recurring trigger point in it that it has been overworking for a muscle who has not been doing its job. We've got slackers and clenchers, so we'd have to identify if that was part of the issue, and I would teach her, okay, you need to be using, in her case, typically it would be muscles down by her shoulder blade to help keep the shoulder blade down. Oftentimes it's the opposing muscle group that is not doing its job. So the needling itself wouldn't be the only thing we would do. I would talk to her about stretching the muscle and because now that it is in a more relaxed state, it's good to take that muscle to its end range. So in her case, she would do something like, this side, she would go something like this to stretch it out, and so that it doesn't go right back to being tightened up as soon as she gets in her car. And those other points I already kind of talked about, retraining the muscles, because I'm always going for the long-term fix. I'm not going for the short-term fix. So, a little history about needling. You've been hearing about it more lately, which is maybe why Linda asked me to speak about it, because it's kind of it's around more. Commonly done by physical therapists. Sometimes there's a chiropractor in town who does it. Some of the DOs are doing it. It's been around for a while, but I think it's just become more popular like in the 80s and 90s. There was a little bit more research, like there were technological changes in, like they saw the Doppler studies where they could identify it. There was some musculoskeletal ultrasound that could help to identify the trigger point. So there's just been better research on it. One of the coolest studies was they were doing some injections and studying, different medications. Would Marcaine be more helpful or lidocaine? And they wanted to have a control, so they put a needle in through trigger points without injecting any medication, and those people got better too. So from that, we kind of learned, you don't need medication. You can use a much finer needle and less chance of reactions to the medication, and a lot simpler to administer. In some states, PTs are not allowed to do it because there has been some controversy with acupuncturists are feeling uncomfortable with PTs doing needling. From my perspective, we've been palpating for years. We're not coming in off the street just poking needles into people. We know our anatomy, we know our physiology, we know kinesiology and where things are at. So to me, it was just a nice adjunct to the work that I was already doing. I already been working on trigger points ever since the first continuing education class that I went to after I graduated was about myofascial trigger points. So I've already been doing it for years and years by the time I learned how to use a sharp implement to treat them. A lot of it came about after the publication of Travell's trigger point manuals. These are fabulous books. That's where that photograph, the picture came from. I'm going to go back to that. I didn't really talk about it. So this picture over here, the white X's represent a typical spot for a trigger point. And it might not be where yours was. I put this one up there because this is a very common one. That muscle is really deep and it lies underneath the long back straps on your back. It goes, as you can see, from the top of the iliac crest, the pelvis, every lumbar vertebrae, and the last rib. And it can rule your life if you've got trigger points in that thing. So the common referral pattern is the red dotted spots, like down into the buttock there and down the leg. That's really common. It's probably as common as this trigger point up here in the upper trapezius. So these books are really helpful in that you can suspect, I think this is a quadratus lumborum. That's the name of that muscle, trigger point, and she will talk about perpetuating factors. If you are using your cane and that is too long, or you sit like this all the time because the armrest is too low because you have short arms. So she helps you to identify some of those perpetuating factors. She talks about how to treat them. Janet Travell is dead now, but she was JFK's surgeon, his physician. She's just brilliant. She was an MD, but she did a lot of work with trigger points, and this manual is what all of the trigger point work is based on pretty much. So if you want to come peek at these, you can, even lay people can learn a lot just by looking at these books. The illustrations are fabulous. And she talks also about aftercare in there, like what to do after you have identified the trigger point and had it treated. So there's reasons why you would not needle someone. If somebody is really freaked out about needles, this is probably not your choice of treatment. Although some people can get over it and get treated with needles, right, Emma? If there's other ways. It's not the only treatment of choice. Metal allergy, this is stainless steel. I haven't had anybody have problems with that. If you already have an infection there, I don't want to be messing around and reintroducing, another entry point for infection. Lymphedema is when it's most common after someone's had a surgery to remove lymph nodes after cancer, and so that the swelling kind of pools in a limb. You wouldn't do it for that reason because they don't have good circulation in that area. There's some cautions which are not contraindications, meaning you have to choose whether you want to do it. Thoracic area, I already talked about with Joan. You've got to be careful because you don't want to poke lungs. I personally don't needle the intercostals, which are the muscles in between the lungs, because for 20 years I used these instead, and those don't poke lungs, so I just go with that. Hemophilia, it's not a bleeding disorder, people who can't clot well. I don't want to make more bleeding in there because that 30 seconds of pressure that I put on afterwards is probably not going to stop them from bleeding, so I don't want to cause a big hematoma. HIV, that's just a caution. One of my instructors was from South Africa, from Johannesburg, and he said over 50% of his population has HIV. He needles all the time. Blood thinning agents, so if someone's on Coumadin, same kind of thing as having clotting problems because of hemophilia, maybe you don't want to do needling because you just don't want to create more bleeding. I wanted to leave lots of time for questions, so questions or comments? Sharon?
What is the difference between the dry needling and acupuncture?
I knew that was going to be the first question. So what's the difference between dry needling and acupuncture? So probably the only similarity is that we use needles. The needling in acupuncture is part of a whole way of looking at things through Chinese traditional medicine. And the goal is different, that we're primarily just going after myofascial trigger points. They look at meridians and energy, and they have points that connect to other organs in the body that we in Western medicine would never really make those connections. And a lot of their work is a little more superficial, although they do some of these deeper points. And a lot of the typical trigger points also correlate with some of their musculoskeletal trigger points that they do, but they're just looking at the body in a whole different way, and the goal is different. Yeah. What else? I like this. I know everybody's name. Lori.
Yeah. HIV consideration is for the practitioner or the patient?
I think that is in there for the for both, because they're more likely to get an infection because they don't have the immune system to fight it. So are you putting them at risk by piercing? It is considered an invasive technique. So are you maybe putting them a little bit at risk for infection? I've never seen an infection, and I've done hundreds and hundreds of needles, but it could be for the patient's perspective. I see very little fluid coming out from my perspective, and it can be mopped up with a little cotton swab really quickly. So I think it's probably more for protection of the patient. Yeah, that's a good question. Yeah.
And secondly, what's your youngest patient?
My youngest patient, Emma, my daughter.
Well, I mean, can you use it in neonatal?
I don't know if they often have trigger points, because their tissues are, she's asking whether I could use it on a baby. I think that their tissues are so supple, and I don't know if they would have issues. Yeah, no baby has asked me. Yeah, so I think probably the youngest would be my daughter Emma, who's 17. I definitely don't do it unless I have patient permission. Most times, if I'm treating teenagers, their patient is there with them. But I just think it hasn't come up to do it anybody younger. Other questions? Yeah, in the back.
Is this something you have to do repeatedly or once or twice works?
She asked whether it should be done repeatedly or once or twice works. It depends. Sometimes I have had it work on patients right away and it lasts for a long, long time. I've got one person who's had this long-standing issue. She came in, and I had seen her before, but now I had this new trick. And she came in, and I needled her, and her pain went away, and it stayed away for 2 years. In 2 years, she came on for another tune-up. Other people, if it's a little bit more acute, it's like currently really bugging them, distracting pain, maybe it's, unlikely it's usually not just one muscle. Usually I got to treat that one, but I got to treat that one, and we have some other work to do. So it kind of depends on the person, how severe it is. If you're lucky, sometimes it has been just once. So it really depends. Sometimes it's multiple muscle groups. Yeah.
Well, you mentioned broken ankle for some reason. Now I don't even remember, except my son had one broken ankle maybe 15 years ago, and it still hurts.
Okay, so her son broke his ankle 15 years ago, and it still hurts. Could be there's things in the myofascial trigger points in the muscles that help to run the ankle. Could be just that the joints don't glide like they need to glide. Sometimes they stay stuck. He should see a physical therapist. That's it. I mean, it might be this. If it's in the ankle joint itself, then less likely to be this, because this occurs more in the muscle tissue rather than in the joint. But yeah, he should see a good PT. Yeah, go ahead.
And it's not for arthritis.
This would not be to treat arthritis, yeah, because that's different. That's degenerative changes in the joint, but there could be myofascial pain in the muscles that run that joint that could contribute, and you can treat those, and sometimes it decreases the compression in the joint, and it can be helpful, even though we're not treating the arthritis itself. It could be helpful, yeah. Who else was like, yeah, go ahead.
Will it help with something like a rotator cuff tear? That was small, but is a year old.
Could it help with an old rotator cuff tear? It might. It kind of depends on if the pain. Sometimes I see with the rotator cuff tears there'll be a lot of compensatory stuff going on in this upper trapezius because the cuff isn't strong and this muscle is overworking, so it could be helpful for that. Probably would it help the tear itself? Not necessarily, but sometimes with little tears in the rotator cuff, if they're not severe and they're not in need of surgery, just changing the mechanics of the shoulder itself can be helpful, like getting the right muscles to do the job.
Well, assume that it hurts enough that
What's that? It hurts enough that you'd be willing to be needled? Is that what you're saying?
Well, does it hurt enough to get over the fear of the needle?
It depends on if your shoulder hurts enough to get over the fear of the needle. Yeah, that's a good. Yeah, that's right. They're really thin. Okay, somebody else had a question. Yeah.
I just wanted to share that I had I met two physical therapists helping me with physical therapy when I was pregnant and carrying.
Yeah.
And I was able to pursue it all through pregnancy and deliver. So it worked for something called interstitial cystitis. So I just wanted to share that if anybody had that experience. It's called pelvic pain clinic in San Francisco.
She had dry needling. The dry needling was a part of it? It was not dry. Just trigger point release while you were pregnant and helped a lot. Yeah, so they maybe didn't want to needle you. Well, I don't know if those therapists did needle, but they might not have wanted to needle you because you were pregnant?
Right.
Yeah.
So it's just,
Use finger pressure and it's really helpful. Great. Love to hear those little success stories. Nobody wants to tell a disaster story, do they? Sharon, you got another one?
It has to do with insurance. I know you don't bill insurance directly, but is it your experience that this kind of treatment is covered by most insurances?
I code it under manual therapy, which I do a lot of, because usually it's not just the only thing I do anyway, so it just gets bundled in a manual therapy code, 97140, which happens to be the same code as raw almonds in the bulk section of Fred Meyer. Yeah.
Would a combination of physical therapy and the needle prove to be beneficial?
Has a combination of physical therapy and needling proved to be beneficial for all things? Well, yes. I mean, you're asking, I've got a biased opinion about that. I mean, yeah, I think it can be. Yeah, I think done on its own, sometimes it can be very helpful too. But like I said, I'm always going for the long-term fix, and I always want to figure out why is that hurting? Not just because it has a trigger point in it, but what caused that trigger point and what's perpetuating it. So that's the kind of things that I like to bring in to help for the long-term fix. Did I answer your question? Okay. Yeah, hi.
Often do patients find and experience intensely painful the needling?
There's probably some people in the room that can speak to that. Yeah. How often do patients find it painful? It can be painful. I personally don't really like to be needled. I've been needled head to toe during my training. I sound like I'm in labor when I get needled, but it's so helpful. It's worth it to me. I think it's painful. Do you think it's painful, Joan?
You know, it's uncomfortable at times because it makes the muscle twitch and you can feel something within the muscle tissue, but I wouldn't call it painful, just uncomfortable.
Sometimes it feels like a funny pressure, like it feels like that needle is big and I don't know, there's odd sensations in there. And I would say each trigger point is different, each person is different too. I might needle one on your neck and you might think, oh wow, and then needle one on your calf and you're like, are you in there? So it really depends on the person and it depends on the trigger point, I think. And I've had that same experience with me. Like some of them, I can't even breathe. Yeah.
Does it require a referral from a physician to come to you?
In the state of Alaska, it does not. We have direct access in Alaska, and anyone can refer themselves to physical therapy. There are some insurances that require it. If Medicare is your primary, they will not reimburse you because I don't participate with Medicare. So I make it a little bit cheaper if patients have Medicare as their primary and still want to come see me. There are just some, like I think Federal Blue Cross requires a physician referral to come see me. So, but if you're not going to bill insurance, then yeah, you can just come. Yeah.
Can needling help a very bad bruise that's very ugly?
Can needling help a bad bruise that's ugly? I think you probably would not want to needle that area.
Increasing the problem.
Yeah, I think so. I think you want to, I think time is your best friend there.
I have another question.
Yeah.
How do you mentioned tendons and ligaments, so
Mm-hmm.
how do you find those? I mean, is it similar to part of them? I mean, it's part of a muscle.
Just knowing your anatomy, knowing where they are, and they're easy to palpate, and yeah, tendons are easy. They're those stringy things. Did I answer your question? Yeah, okay.
What about something like sciatica?
Something like sciatica. So if the sciatica is being caused by a herniated disc that is then pressing on a peripheral nerve, or the sciatic nerve is a peripheral nerve, then it's not going to do anything for that directly, but I find that very often the nerve irritates the muscles along the path of the nerve, and then when the muscles contract, they in turn irritate the nerve. So treating the muscles can be somewhat helpful for sciatica. Yeah, not the only cure. You got to do your homework and do your core work, but yeah, it can be helpful. Lori?
What about phantom limb pain and amputees? Is there any corollary with the remaining limb that you could treat that would do something about phantom pain?
She's asking about phantom pain with an amputee. I have never seen anything about that. she's asking about phantom pain, which is for an amputee who has already had a limb cut off. Sometimes they still feel pain in that limb. I don't know if that would do anything for it. It's an interesting question. I've not seen any references to that. Peg, you got any ideas about that? No. Okay, well, who else? Anybody else got a question? No? Okay. That's it, thanks.